Okay, this is Matthew Holt, publisher, editor, founder of the Healthcare blog, and we're back with the second episode today. It is March the 26th, 2020. I sound a bit like Brian Williams, where he says it's day 1023 of the Trump presidency. It's sort of like day 30 odd of the crisis, in about 2.5 weeks since the coronavirus meant the NBA got cancelled and things got really panicky. So with that, we're going to go live with the THCB gang. It's our second group of the gang. We only have one holdover from last week. So guests line up. We're going to have, you'll see Michael Millicent, Vince Caritis, Grace Cordovano, Brian Clapper, Ian Morrison, and Anish Coker is a late addition. So Zoya, if we're ready, let's go live. Hi, everyone. Oh, everyone's still muted. So right now I'm just talking, but let me start. Unmute them and I'll introduce everybody. From the top, I don't know if I exactly see the way that you'll see them on the screen, but from the top left, Grace Cordovano, patient advocate, cancer survivor, and generally cool person who cares a lot about data. Michael Millicent, bro, old lag, like even older than me, author way back when of Demanding Medical Excellence, and way back when, reporter of the Chicago Tribune, when they could still afford reporters. Ian Morrison, holdover from last week, my former boss at IFTF, well-known healthcare futurist. Vince Caritis, who's known to THCB readers as the guy who is working with Devin McGraw, who was on last week on the Privacy Conundrum, but long-time healthcare consultant. Brian Clapper, hanging out these days at the Validation Institute and doing employer-based stuff, but again, a long-time healthcare consultant. And Anish Coker, who's joined us from Philadelphia, cardiologist and contrarian, I would say, who has his own podcast and publishes on THCB and elsewhere fairly regularly. So with that, let's get going. I wanted to start, we keep on getting and losing Anish, hopefully he'll come back. We'll do the full Hollywood Squares last time. I want to start with where people think we are in the coronavirus COVID-19 crisis overall, particularly the issue around, just this morning, I saw some stuff saying that the people who at Imperial College who wrote the piece saying that basically we were all going to die a couple of weeks ago, which actually changed the British government's idea, has now sort of walked that back and saying that perhaps it's not going to be so bad. Having said that, you're seeing at least New York, New Orleans, Seattle in this country, and obviously still Northern Italy, and it's starting to happen in London and elsewhere. Definitely happening in Spain, of course, Madrid and Barcelona, starting to get really bad in terms of the use of, in the way that we're seeing intensive care units getting overwhelmed, the hospitals getting overwhelmed, and lack of supplies and ventilators and what have you. Who's got an opinion? Anyone can start. Who's got an opinion for where we are now and what the real truth is?
I'll give it a go. So it's not even the virus that's the problem at this point. I'm more worried about if myself or a loved one really need a ventilator. So I'm in a New Jersey, New York area, and what my colleagues in medicine and good friends are telling me is really concerning. And then there's also the concept that if it's your child, if it's your grandparent, if it's your spouse or your loved one, you can't go and visit. You're outside on the glass. There's no human touch. You're being put on a potential ventilator. You can't communicate your wishes. Boots on the ground, it's a very scary situation. And I think that's where, when you really start talking about what you're worried about, that's really the fears, that it can collapse your whole family dynamic and really your whole life, based on whether or not you can have access to the tools, information, and technology to get the care that you need at that time.
And if I may add, Matthew,
dive in, Vince, don't be shy.
In the absence of federal leadership, it's every state or locality, you're on your own.
I think there's, I think I don't know if it's coming through with the amount of information on COVID. I see a lot of US maps. Clearly, this is a problem that right now is hyper confined to, no, I shouldn't say confined is the wrong word, but clearly the epicenter in the world right now is the New York and the metro and the New York metro area. So there's 60 to 70% of the new cases are happening in those 4 counties, New York, Suffolk, Nassau, and then we have, Bergen County that's right next door, the county that's adjacent in Connecticut. So the huge problem. I mean, you're talking 11,000 new cases, or 10,000, 11,000 new cases. Almost 6,000 to 7,000 of them are coming from those areas. So that certainly is the epicenter, and that's the focus, and that's where, you know, folks are, their health systems in New York City are under a tremendous amount of strain. And there is a tremendous amount of panic that is deservedly so occurring because of it. I've had multiple conversations with physicians on the ground who are working, you know, ER physicians. We just did a podcast last night and put it out last night with somebody who's an ER physician who's kind of seen this thing unroll over the last 10 days. And it really is really remarkable to see how quickly it progresses. It progresses from a bunch of, you know, this is just 12 days ago, a bunch of people coming in worried, well, you know, I'm short of breath, I have a fever, and, you know, people saying, okay, go home, we're going to test you. And then suddenly, very rapidly, in 3, 4, 5 days, you're inundated with people that are coming in, not because they're worried, well, because they can't breathe, they're short of breath. And suddenly, you know, you've turned from, you know, 20% of your cases being short of breath pneumonias to 80 or 90% of the people now showing up and hitting the door are short of breath, have pneumonia, and are too sick at this point to go home. Some percentage of them, you know, as Andrew Cuomo was nicely showing the New York stats, 3% of them are ending up needing to be put on a ventilator. So it's clearly something to be very worried about. Though the thing that I'll point out is the real story may be how, and this is what I'm not seeing put out, is how these physicians, these health systems on the ground are adapting in an unbelievable way. You know, the gentleman I spoke to yesterday, they've increased their bed capacity by 100%. They've doubled the number of beds they have. They found staff to staff those beds. They were running incredibly low on PPE. They've come up with ways to try to make the PPE they have go longer until, you know, the cavalry in terms of other PPE arrived. And really, you know, really remarkable stories in terms of how that's happening. As of this morning, actually, and yesterday morning, the hospital systems in New York that are getting slammed by this tsunami of patients have yet to ask the New York, you know, the governor for ventilators. So they are right now, they are, you know, very impressively managing this massive surge that they're seeing. So, I mean, I would like to see, I think there needs to be a certain amount of panic that we want to create because you want people to stay at home. I mean, I get so frustrated with seeing these pictures of subways, even yesterday, still crowded, you know, in New York, you know, playgrounds and parks that still have a lot of people. So you want a certain amount of panic to say, hey, this is serious. You really need to isolate and stay away from people, distance and whatnot. On the other hand, you don't want people to have what Grace is talking about, which is, my God, what is going to happen? You know, if I get there, there's not going to be a ventilator for me. Certainly at the moment, the health system in New York is responding in an incredibly impressive way to an unprecedented surge. And this is without right now help coming in from the feds in terms of, you know, there are 11,000 ventilators in New York that are waiting to be deployed. The reason they haven't been deployed from the central authority in New York to hospitals is that the hospitals have not asked for them. PPE is sitting on hand in New York State. The reason that it has not been deployed is that the local hospital systems have amazingly been able to acquire, you know, PPE in order to, you know, in order to get that serviceable for them for what they need at the moment. So the message, you know, it should be kind of two-pronged. I'm sorry I'm speaking so long. That yes, you need to be panicked. This is something serious. This is not just the flu. On the other hand, you know, the U.S. healthcare system, certainly the New York health system, is you know, performing in a heroic manner right now to service the needs that there are. And there are plans. Every single chair of the department, every single physician in any type of lead role, and even the folks on the front lines and in the trenches, nurses, doctors, intensive care doctors, are working overtime to figure out how to generate even more capacity, because it's certainly in the case that we're going to need additional capacity.
Yeah, let me say two quick things. One is that get the Akal and Coca report, which is the podcast you mentioned at all of your good local podcast stores. I guess they're only online these days. Yeah. And secondly, as I think I mentioned last week, I'm involved with this group COVID Vent, led by Adam Shifke, a Stanford anesthesiologist who's trying to get basically a system for converting ASCs, ambulatory surgery centers, which have got a bunch of ventilators that are going unused as elective surgery goes away or gets toned down. Well, they're still doing their elective surgery at UCSF because they're kind of containing the surge in San Francisco. And I think the difference between different places is very interesting, and whether the question we'll get into is whether actually the fact that Californians were not down for a couple of weeks made a difference or not. Michael.
So a couple of things. First of all, I think Anish, you meant to say that New York is the epicenter of the U.S., not the world, right? I mean, given what's happening in Spain.
Isn't New York always the epicenter of the world? Whatever it is.
I mean, we're seeing the way we're testing the density. I mean, I don't know the exact numbers in Spain. I know there are more deaths. There's certainly more deaths in Spain per day. In terms of new cases per day. In terms of new cases per day.
Right. So a couple of things. So my son worked in rural Mississippi for a couple of years. And when you look at where the cases are, it won't get much attention from the morning news shows, but now you have this virus even in rural Mississippi, the county that he worked in, right? So it's not just 50 states. You're having it with people that, if they travel 60 miles, that's a big deal. They're not traveling internationally. And that's a harbinger of something, right? That hasn't gotten much attention. And just like, although we talk about there being enough ventilators or whatever, when I'm not sure that there are, but you're looking out towards tomorrow. So I think that if you look towards places outside New York that are not as dense, and you start to see some of these trends, I think that's kind of worrisome. The second thing is that, I've looked at all the studies that say, I need to say it's overblown and other things like that. So I think you have to go to a reality test as well as an academic test, right? So if this is just peer-reviewed papers, you can go to one estimate for the R factor, another estimate, and go, well, who's got the better algorithm? But then you go, all right, let's not look at China, the reporting issues. Let's look at Italy and Spain. And if you look at Italy and you're thinking about the death rate, you say, all right, the reason so many coffins are piled up there, or the reason so many people dying is that all of those people are smokers over the age of 60, right? Or somebody with other factors, or is this something that we should learn from? And I think when you talk about it being less fatal, and I think there are some good, data which talk about the rate of death that might be less, but it also talks about the infectiousness, which it can still be incredibly expensive and awful. Even if you don't die, you're alone on a ventilator in an ICU for a week. You didn't die, but as Grace said, that all the experience of that. But if you don't have some explanation for why there's so many deaths in places like Italy and Spain, I think your algorithms may be beautiful, but you have some explaining to do. So I agree with Anish, you don't want to panic, but you also don't want to get caught up in angels on the head of a pin, which academics love to do, and instead say, okay, great. I get it. Your algorithm says this, your algorithm says that. And by the way, Matthew, anything that comes with the word imperial, we have to believe, right? I mean, it comes from Crown, British. I mean, it's got to be right. Maybe Prince Charles can deliver the estimate. Explain the on-the-ground reality to me that it fits what your theory is. And that's one thing that I think we haven't quite seen yet.
Yeah.
I have to jump in here. I have to just push back. Anish, I'm on the last few days and nights been on the phone speaking with hospitals, nurses, doctors, first responders, care teams, and they are in the Bergen County, New York City area, and they are short of PPE. They are short of gloves, masks, sanitizer. So why we're not deploying? We're literally, there's a group of national volunteers that are looking, excuse me one second, they're deploying, why they're not deploying this when there's shortages that are being reported and people are using garbage bags as gowns, and we're looking at jerry-rigging ventilators and 3D printing shields. We're looking for donations of 10 masks at a time. This is just not efficient and it's unnecessary. We have it, deploy it.
Well, no, but there's a problem with that. The problem is that we have a look. This is completely unprecedented in terms of how we normally operate. The way we normally operate. Look, number one, there's no question that we all need more PPE. I have one N95 that I've been using for the last 3 days. I would love to have I'd love to have more. So there's no disagreement about it. The problem is that in the places, in the way we normally operate, the way we normally stock supplies in hospitals or have, it is not to be able to deal with this type of a pandemic. And maybe that was a big mistake. The hospitals are not stocked in the way we use PPE to deal with a pandemic. So just to give you an idea, New York Presby normally uses 5,000 surgical masks a day. That sounds like a lot, right? Right now, or early on, they were using 70,000 surgical masks a day. There is, simply put, there is just, I mean, there's no, the supply chain for healthcare, it sucks because it's a massively overregulated business where there's a few suppliers that meet some FDA criteria that's probably somewhat irrelevant, and therefore 3M with their N95.
I want to interrupt you since I know a little bit about supply chain. I did some stuff with them. What they also done, it's not necessarily massive overregulated. It's the fact that they went to just-in-time delivery,
Right.
so they cut costs, right? So to say it's regulation, in fact, it's on the opposite, that it's not geared up for a pandemic. It's geared up for every day. So you go to just-in-time, and then when you don't have just-in-time, like you and me going to the grocery store, you end up with massive shortages. So it's not because of the fact that there are only a few suppliers. It's that we're geared up, as you said, for every day, and that's the way to make the most efficient use of your resources.
Yeah, but Matthew, coming back to your original question, I mean, this shouldn't be kind of a debating epidemiologist's hour. I actually talked to my daughter this morning who has an MPH in epidemiology, and she said she's sick to death of people claiming they're amateur epidemiologists now. But the point is that what can you do about it? And the short answer seems to be social isolation. Staying at home is the only proactive response to forestall these kind of tsunamis. And I think we raised this on the gang last week, is that the geography of this is going to become very important because of the differences. It's very important politically, and it's very important in terms of caregivers. I mean, I, like many of you, I'm sure, tracking Bob Walter's daily missive from UCSF versus Columbia. And I'm also on the United States of Care Council, and heard Levitt, Governor Levitt, who I'm advisor to, do a thing earlier this week. I think everybody's recognizing it, no matter what your point of view on the spread and the rate, that the response has got to be proactive measures to stay at home on the one hand, get test production up, get PPE production up, and do whatever we can to protect our frontline staff. Because I come back to where Grace started. 1% death rate doesn't sound a lot unless it's your family, right? And that's the problem here. Sure, it might look like the profile of the flu to some epidemiologists, but I've never seen a flu swamp New York Presbyterian before. And I think we just got to get our heads around that, and we can't underreact.
But let me just finish the one thing. We cannot, in the face of a pandemic, operate under the same rules that we operated on when we don't have a pandemic. So the issue is here is it's two-pronged in terms of PPE. Yes, there's a supply chain issue. We can argue about why it is 3M has 30 million, there's 30 million a month that they make that aren't able to be used by us, and that's probably because of some regulatory thing. The just-in-time stuff, also there are issues in terms of supply chain. There's no question that it's multifactorial. But the other part is that we cannot burn through PPE the way we normally do, because there is no country in the there's nothing in the world will allow us to restock in that manner. I mean, we cannot burn through 70,000 surgical masks a day when you're facing a pandemic. So the normal rules that we have, means for one patient who's in isolation, every time we go into that room and we come out, the current regulations, right, which have, by the way, have been abandoned by any hospital that is dealing with this in the flood situation. Every time you go into the room, that means every nurse, every tech, every physician, every resident, every fellow, right? Maybe 5 or 6 different people will go in to see one sick patient in an isolation room, right? every time you go in and out of the room, the regulations were, and the regulations have been, and this is what we're stocked for, is you use one N95, right? So one patient in 1 hour, 6 people going in and out of the room, you know, six N95s done, used, right? So clearly, I mean, part of the issue, there's no question. Look, again, I'm sitting on, I'm going to the hospital every day where there are COVID positive patients. Yeah, I would love to have more N95s. We don't have more. We don't have enough. We need more scaled up, built. Hopefully, they're on the way from Apple and wherever. But part of the issue, is that we're burning through stuff way too fast, and we have to quickly change and operate. And to the credit, and that's what I meant by talking about the story on the ground. Certainly, you know, it's on a podcast. It's on an anonymous post of a text message. I spoke to them for an hour and 10 minutes. It's that, you know, they realized very quickly they had to adapt to the realities of, you know, not being able to go through 10 N95s, you know, every 15 minutes based on how many people. You have to cohort who goes in rooms. You have to cohort patients. You have to cohort whole units, you know, COVID positive units. You have to do what they did in China, what they're doing in Italy, which is have one person with a significant amount of PPE, and that person stays in that PPE for the entire shift, as opposed to changing in and out of that PPE, you know, on an hourly basis.
And I read about that, and each people staying in, you know, in the US, people staying in their uniform for the whole shift and staying in, you know, PPE for the whole time. So this gets us to a bigger point, and I want to bring Brian and Vince in on this one, which is the idea that, and I'm hearing it in a couple of editorials already, that we have to prep our system for a surge, for a pandemic, you know, which we're not prepped for. And do we just deal with it now and then figure it out? Because you can imagine coming down the track here, and Brian, you've been arguing about this for 20 years plus. Are we not just saying, well, you know, we should spend more on the healthcare system and give it more money, and then be ready for this when it's a 1 in 100 years or 1 in the 50 year or 1 in 10 year eventuality? And I think that there's a question coming up now. We've just had, has it been signed yet, the $2 trillion package, which has got, you know, a bunch of money in there. I'm wondering how this is going to play out in a world in which you have two interesting things going on. One is we're going to reduce elective surgeries, or what is an elective surgery? And are we going to we're reducing them, but, you know, are they necessary or unnecessary? I know Grace, you have some thoughts about that. And two is that we're going to have, you know, a hue and cry to make sure we're ready for the next one, which probably means building a whole lot more hospitals. So, Brian, you got some thoughts about that, given what you've been saying over the last few decades about overuse of the system?
Well, it's trivial to, I mean, the reason we're here is because there's no financial incentive to invest in public health to begin with. But if we had made certain preparations, it would have been a trivial addition to what we're already spending, which is a crazy amount of money. We're spending basically double what we should be spending, or 2.5 times what we should be spending. Our problem, which is historical, is exacerbated by the fact that we have an imbecile in the White House, and we have no leadership at all, and we have a guy who believes in fantasies rather than science.
So I think the whole what's currently happened directly rebuts Brian's point. So I completely disagree with Brian. So I'll tell you why. I said when Italy, you know, I don't know, you can find a tweet from a week ago just to prove that what I'm saying is right. Is that I said that, look, the U.S. system has a massive amount of capacity to deal with pandemics exactly because we do so much elective surgery. So, you know, basically, and I don't know that this can happen in most hospitals, I seriously doubt it. Basically, every single hospital in New York City has expanded capacity within 8 days. They have expanded bed capacity by 50 to 100%. They have added, the North Shore Hospital I spoke to yesterday, they've added 3 intensive care units. just again, and snap finger. And again, that is not just adding beds, that's also adding staff. So it's interesting to think that massive elective capacity that we have, that can be deferred, all those knee replacements, those spine procedures that may, you know, we can argue about whether they really need to be done or not. All that massive capacity, it really, in 5 to 6, 7 days, can be turned on in this massive way. So
Well, you're arguing
and
that it-
wait,
you're
wait, wait,
arguing
Hey,
that it's
Matthew,
directly
can I hop
convertible.
in?
Dive in, come. Brian, then Vince, quick.
Yeah, you're arguing that it's directly convertible, and it's not. I
It is. It's happening right now.
Well,
It's happening right now.
because they're making do as it's catch as catch can. But
No, Brian, think about this. With the massive tsunami and surge that's happened in New York, New York is dealing with 6,000 new cases a day. Wuhan, when they shut down, we're dealing with 2,500 new cases a day, all right? And when that happened, Wuhan had to build 2 brand new hospitals, right, for COVID-only patients, all
you're
right?
saying that
We're
because
dealing
of
with
our-
New York City with 6,000 to 7,000 new cases a day, which is 3 times what Wuhan was doing, right?
So you're
the-
saying
the
that because
hospitals-
of our incredible oversupply, because of our incredible overtreatment.
Yes, that
whoa,
elective
hold
stuff,
on.
that's redundancy.
Okay. Oh,
Redundancy
Vince,
that's being applied for
all right.
COVID. And it's,
Okay.
and it's
Yeah,
happening right now.
I'd like to
All
back
right,
up the
Vince,
train a
Vince,
little
then
bit here.
Grace. Let's get the argument going here.
Okay, I'm going into AFib listening to this, so hold on 1 second. I will just say, so just for background, so my day-to-day advocacy work is working with people who are high risk, who are chronically ill, who are being treated for some sort of cancer survivors, immune compromised. When we talk about electives being canceled, the people in my area, again, New York, New Jersey hotspots, who are electives are the likes of a lung being removed to manage a tumor that can't be treated. I mean, we're talking about not like plastic surgery and like nice to haves. Everything has been cut off in some cases or postponed
Grace,
to deal with the influx.
But Grace,
Hang on, Anish, give Vince a second. Anish, give Vince a
Oh,
second.
sorry.
He's been trying to get in for a while.
I'm just saying that there's a lot of patients who are in a state of limbo right now, in a holding pattern, not getting information, who are dealing with an active cancer diagnosis, who are struggling to update advanced directives, who I'm leading tough conversations. Do they want to be put on a ventilator? Is their cancer going to progress? What happens here? So there is a lot of uncertainty. I'm not saying that this isn't necessary, but when we talk about electives, we do need to be mindful that there's a lot of things that maybe aren't elective to a person dealing with cancer or another chronic illness with multiple comorbidities.
But Grace, you're not arguing, are you, that we don't have a serious overtreatment problem?
I didn't say that. I'm concerned about the electives, that we can just shut off the electives.
I agree.
And
It's the question, what do you call an elective? Right. Vince, you've been trying to get in for a while.
Yeah, I've been trying to hop in here. So I'd like to back up the train a little bit. I appreciate that you're all in the middle of this. And at some point, we're going to need to step back. I think the perspective I'd like to bring is to ask, what is the role of technology and being able to address this issue? Anish, you referenced Wuhan. So let's talk about an example that I think is carried out very differently in different parts of the world. And that's smartphone technology and being able to detect people who are carriers or who are in contact with people who have been carriers. In Wuhan, in China, the way they're approaching this is very authoritarian. You are on a system and the government controls it.
Same thing in Taiwan, right?
I'm sorry?
Same thing in Taiwan.
No, it's actually quite different in Taiwan.
Okay.
And I'm going to use that as an example, though. But, we have an authoritarian approach. And, we think as Americans fairly negatively, I think, about China. But recently I saw the Edelman Trust Barometer. 80% of Chinese people trust their government. And the very authoritarian approach.
80% of people answering a survey in an authoritarian government say they trust the government.
Hey, Michael, can I make my point, please?
Michael, let Vince finish.
Yeah. That's being monitored by everything they say is being monitored, and they say they trust the government.
Michael, let Vince finish. We get your point.
So my point is, in China, it's worked pretty well. And if you are, so the example is, if you are designated through the GPS on your phone as being a carrier, you come in contact with someone, that person is likely to get a text message that says you've been in contact with somebody that is a carrier of the virus. I mean, it's very, very top down and controlled. In Taiwan, just read an article this morning, and I referenced it in my Twitter account. It's really much more bottoms up, and it's a voluntary platform that people are participating in democratically, where you can ask to be notified where maybe have I been in contact with somebody who is a carrier? And contrast with that with the US, where it's pretty much laissez-faire. We don't really have a system to be able to take advantage of this technology. So, you know, I'm planting a seed. This is really not the time to finalize this discussion, but it's a way of thinking about this quite differently, as opposed to dealing with the, you know, the end of the crisis that everyone else is talking about today.
So I want to get back to this one, which is two questions for the group. One is, when's the, you know, going back to the thing about the Imperial College and looking at Unitas and the other, you know, is it a big deal? Is it not a big deal? When is the end of the crisis? I mean, Trump wants us to go back to church at Easter or something. What do you want to do? Wants us to pray for our salvation? For
we have a pretty good indicator for that. The metric is R, you know, and when we get that, that's the reproduction rate down below 1, you know, to me that becomes the metric.
But how do we even know
apply that to locality?
Right? I mean, all we can have to guess as to when the number of people showing up at ICUs in different cities gets to a manageable level.
But I think that's why Vince's comment is not far in the future. I mean,
right.
There are two fundamental problems. One is we've got this surge right now and dealing with that, and I still think we haven't exhausted our innovation around being able to identify teams to support the places that hit that wall. That's the conversation we had. But you're asking the right question, Matthew. When is it going to be safe to go out? And the answer is we have no bloody idea, because we don't have any community-based surveillance and testing, right? And anyone who says otherwise is lying through their teeth. So it seems to me that one solution is—
what side do you err on? Do you err on the side of saying, well, since we don't know, we'll just let people go to church on Easter Sunday? Or do you say we'll continue the lockdown to be sure that's not overly protective?
I would suggest you might get resurrected by Easter, but I don't think you're going back to work. I don't think you're going back to work till Labor Day.
I am tempted to let Donald Trump go to church on Easter Sunday.
Donald Trump's never been to church his life. Supported by
and I would like him to shake hands and hug everyone.
We need a tech-enabled third option.
We
need a tech-enabled third option so we can actually function here, because everyone's incapacitated because we don't have access to the data and information to proceed.
I mean, let me say one thing to Grace, and then go to Michael. I think what you said is great, Grace. I've got at least 3 clients who are trying to do something. One has got a thing where they figured out, they believe, based on all the medical records of complex patients, which ones are the most likely to be in real trouble if they get it, so they can be got to isolated soon. And the other one's got a sort of a sort of symptom checker daily updating device where you can try to figure out, and there's people who are using the Kinsa thermometer, who've been trying to figure out where the hospitals are. So you can kind of see this, but none of this stuff is anywhere close to being ready if we're making a decision in 2 to 4 weeks.
Right.
This stuff which will be ready for So Michael and then Anish. Sorry, Michael, go, then Anish.
So real quickly, first of all, I would be careful about making proclamations about U.S. hospitals based on the East Coast or the West Coast. As someone who is in Chicago, there is in fact many people who live between the East Coast and the West Coast, shocking as that may be. Some of us live in villages larger than a few people, like Chicago. So I would be careful about making conclusions anyway about all the U.S. The second thing is I want to make an authoritarian analogy. The lack of testing, to me, it occurred to me, is kind of like when in Germany or other places, you didn't know who was a member of the secret police, right? You didn't know who was an informer. So you don't know who you can talk to or get close to. And that's kind of what we are without testing. You don't know whether that person next to you who looks totally harmless is actually carrying the virus, right? And so you can't get too close to them. And sort of we almost have an authoritarian equivalent of secret police with the virus for everything that's going on. And the last thing, and this goes to the surveillance, in Israel, which is in fact a democracy, there's a huge controversy because Netanyahu has enlisted the Shin Bet, which is their sort of CIA, FBI, NSA rolled into one, to use the same surveillance technology it uses to find terrorists to see who's going outside their house, who shouldn't be, who has an infection. And you're not supposed to use that kind of technology domestically on non-terrorists. And part of the issue with some of the technology is folks are objecting that just because monitoring your cell phone shows something, cell phone towers are not as accurate as you might think in the movies, and so you're going to say someone ought to be arrested or something done to them because they wandered outside, and do you actually get the signal right? So they haven't gotten as much publicity, but they are trying to do some of that as well. Just a brief note, their monitoring technology, at least for terrorism, is good enough, is when they would bomb someplace in the Gaza Strip, they would send text messages to people in the apartment building of the terrorists that they were about to bomb.
Get out.
Seriously, they would send text messages to that apartment building that says, we're going to bomb this, please leave. And they would do this not only in the Gaza Strip, but in Lebanon as well. So I suppose it must be rather surprising to be in Beirut or the Gaza Strip and have a little text message from the Israeli military saying you might want to leave. So that's
didn't we do that to everyone in Hawaii a couple of years ago? Say that there's a nuclear missile about to go off. And then you were trying to get in. I don't know if you remember the topic you were talking about before we started digging over the terrorism. But
yeah, there's so many points. I don't know everybody. Well, number one, I don't know that. I have a hard time believing there's a Silicon Valley solution here. Partly because we fail at the simple stuff, right? I mean, as of yesterday evening, the subway in New York, which is the epicenter in the US and probably the world when it comes to new cases a day, 7,000 new cases a day in the surrounding area, the subway is still running. Cuomo has asked since the 22nd, the 23rd, he has asked for a plan from New York City to say, what do we do about the New York City parks? Because there are way too many people that are congregating there. Still no word on that. As of yesterday and of today, you cannot get the governor of New York, Andrew Cuomo, to say, by the way, I think he's doing a tremendous job. His press conferences are fantastic. So this is not a knock on him per se, but but this particular thing sticks in my craw. He is still saying if somebody from New York, where the attack rate is somewhere between 1 in 1,000 to 1 in 100, or who knows what percentage of New Yorkers are infected in some way or the other with this virus. He is saying, when asked directly, if somebody from New York leaves the state or leaves New York City and goes somewhere, should they quarantine for 14 days? He is still saying, with the support of his physician who sits next to him, he is still saying no. So, I mean, we are so far removed from some of these even higher tech solutions in terms of your phone, and if you get too close, or it'll tell us something. I mean, we can't get basic stuff done. We can't effectively shut down the epicenter of the world, New York City. So I don't see where it is we're going to come up with other solutions. And I'd be interested from the group as to why this isn't. By the way, I don't see coverage of that. I don't see a lot of coverage on why New York City is not effectively locked down. Look, Philadelphia right now is relatively controlled, right? We have some cases, but nothing. And by the way, it's not just because we're not testing. I run primary care at my office every day. I'm not getting inundated with calls like my New York colleagues are for fever, cough, shortness of breath, et cetera, right? The number of people I have sent people for tests. The number of people I've sent for tests in the last week is around 8. I have a drive-through testing center that I walk by every day when I go to the hospital. There's security guards that are there. They stand there all day looking at it. I ask them at the end of the day, hey, how many people have gone through there? Because I don't see many people going through the drive-through testing center. And they say, well, it's about 50, 60, 70 cars. Our percent prevalence, percent positive cases in Philadelphia right now is about 6 to 7 to 8%. So it's clearly the case that you have massive transmission, community transmission, massive community prevalence in New York City. The biggest danger to Philadelphia is not ongoing community transmission here. We've proven over the last 10 days that we did not have what New York City had, right? The biggest danger to Philadelphia, the biggest danger to the rest of the country and maybe even the world is folks from New York spreading this to other, spreading this and creating, seeding, other places. So I'd be curious from the group as to why it is we're not hearing more on that front.
I'm actually not surprised. The same thing with Seattle, and we could start calling it the New York virus. Trump could do that. That'll play well in the red state.
At this point, it is the New York virus.
But no, I agree. Look, in California, we were shut down a while ago, but I live in Marin County, which is the fancy bit across the Golden Gate Bridge, which has all the headlands and the parks and whatever. And on Sunday, the San Francisco Chronicle wrote an article saying, if you're locked down in San Francisco, go to Marin, go walking in the parks for exercise. Now, I went mountain biking on Saturday night, and I'd never seen so many people on the mountain biking trail. And the next day, the Marin County parks have closed all the parking lots, so only us locals can go. So, we're okay. Screw the rest of you.
Can we talk about something? Can we talk about the things that are working? I'm seeing a lot of positives with telemedicine. So a lot of patients were not able to go do a secure chat with their doctor or do a virtual consult. So a lot of red tape has been removed there. I think that is important to acknowledge. I love what I'm seeing there. I actually am seeing more problems on the provider and physician side trying to get the technology up to speed and their staff up to speed. I mean, patients are ready for it. They want it. And actually, we're seeing now that people really want access to their medical records because they're being asked questions and medical history and details on the fly through their virtual consults with maybe team members that they don't normally see and caregivers they don't normally see. So I do see that that's a big barrier. And technology-wise, something that's missing as we're doing all of these new trials in the United States, especially in hotspot areas, there's nothing to really connect patients to these clinical trials. We are in mass chaos. So people want to connect their critically ill loved one to a trial. Can't get a point person, you can't get an investigator, you call the number, you can't get a call back. Something that I'm working on and collaborating right now is this new option to do the COVID positive convalescent plasma trial. How do you connect people who have recovered, who are 14 days clear of symptoms, who are willing to donate blood for a plasma donation? How do you connect them? We don't have time, clock is ticking. So this is where I'd like to see more on technology. I mean, I'd love to hear your thoughts on, this latest uptake on virtual and telemedicine.
Well, all the telemedicine people I've been talking with, and been a fair amount, been pinging around there, and Jess the Master interviewed Jamie Edwards from Cloudbreak. He's basically saying, it's our moment. It's arrived in one day. Finally, after screwing around for 15 years, we are finally the poster child for how to get this right. And it's not going to go back. And I'm not sure if that's the case, but, people are understanding this in a way that they haven't done before. And a lot of doctors who never did it before are now doing it full time. My sister-in-law is a social worker at Kaiser, and she's doing it now, having, sat in the ER, dealing with sort of, social work cases there. So, yeah, I think it is a change, and maybe the sort of digital health stuff that I've been rambling on about for quite a while by now is kind of coming true. On the other hand, that there are still going to be lots of problems, and a lot of this stuff, there's a lot of problems scaling this up. And a lot of this stuff hasn't probably been integrated into the way that people do day-to-day services. I mean, Ian, you gave a talk at Health Duplo like 4 years ago saying we want all this stuff to come from the doctors and physicians that we already understand, and that still hasn't really happened yet. It's still sort of teledoc and doctors on demand trying to ramp up quickly.
Matthew, my 2 cents, if I may.
Yeah.
So
don't ask permission, Vince, dive in. You get the spirit.
I work as a healthcare strategy consultant. My first client relating to telehealth technology was back in 2001, and I've worked with probably over a dozen companies. What I'm really seeing now is a sea shift where the mindset is not pushing back on telehealth and telemedicine technology, but asking, how do we bring it into the system? So, my thinking is really around the big picture and the synthesis. We're going to need, clearly we're headed towards a new normal on a lot of fronts, on the role of technology, on privacy, of mobility in our country, the role of government. It's too early to conclude on this, but it's not too early to be asking the questions and to begin the thinking about what that needs to look like. It's not going to be the world of the past that we've seen.
So let me, I want to go to Brian for a comment on something we haven't talked much about, which is the role of employers and payers in all this. But I want you all to be thinking about what Vince just said, which is there's a new normal. So I'm going to, we're about sort of 5-8 minutes before we wrap up. What is the, be thinking about what is the new normal? I'll be asking you for a comment about that and what we're going to expect. But Brian, one thing we haven't talked much about is that, you know, a lot of, whenever all the people in who want to change healthcare and disrupt it, so they want to do something, they try and go sell something to an employer because they can't get a plan or a provider that's in the system now to do anything about it. A lot of the sort of the new insurgent sort of health 2.0 digital health companies have gone that route. Some of it's been real, some of it's been bullshit, as you know, from where you sit in the Validation Institute. But,
Sure.
you know, where the hell are they in what's going on now, other than panicking about the fact that their revenue is about to collapse?
Well, I think that they're confused and they're waiting to see how things wash out. I agree with Grace that telemedicine is going to be a huge new vector in the system. I agree with you sort of. I think it's not going back. It'll of course go back somewhat because there's a lot of instances where we really need to have hands-on a patient. But any instance that we find could be used through telemedicine will be. The employer community, I think, is going to get hammered economically in this event, and it's going to change our entire social structure and our safety net structure. So I think that there are big changes for healthcare, and now would be the prime opportunity to really go to value in the reimbursement system. It's the chance that we've been looking for a long time.
Well, I mean, that's a point, right? So that all the providers who are complaining about losing elective surgery, or the primary care docs who are talking about people not coming in, they're all still paid fee for service. I mean, do you think that's what's the quick sort of thinking from the group? Let's start with you, Brian, and then maybe you, Ian. What's your thought about the chance of that rolling over quickly now, or because we've been talking about this for forever?
When this is over enough to get back to some degree of normalcy, we're going to find that employers can't afford what the healthcare system expects anymore, and they're going to drop a whole bunch of people off the system, and that's going to set the tone of the new regime. I think we've got big changes ahead.
Well, I think I'm looking forward to Anisha's blog post about how, when we're all on Medicaid, how much fun it's going to be practicing cardiology. But we'll hold that until next week or the week after. But Ian, quick comment.
Well, I know, I think Brian's right. I mean, I think there are going to be some new things, some new normal things like telehealth. You know, I don't think that genie's going back in the bottle. But you know, the providers are going to have to deal with the payer mix damage that's happened through this period of weaning off electives. And I do think, you know, remember, it's an election year. We've forgotten all of that. That it's going to be part of the ideological debate, how this thing plays out, whether government came through or the private sector came through, and the balance of that. So the political environment is going to be affected over the next 60 days massively by how this turns out. But I do think it's going to call into question for employers whether they can still hang in there, because a lot of employer classes are going to get taken out over the next 6 months.
Well, a lot of employers themselves are just, you know, like we said, Gavin Newsom gave a good press conference yesterday. He's not getting the plaudits that Cuomo is, but he's looking fairly sensible, given that we were looking for a sensible Democrat, and we didn't find one apparently in the 97 people who ran in the primaries. We ended up with Joe Biden, God help us. Not that I'll vote for him because I'm a good Democrat, but you know, I thought what he said was that the change in California has been so fast, and you've had 1 million people registering for unemployment. You know, out of things, you know, all the restaurants are closed, all the events are done, and you know, it's only so much that rich sports stars can do by, you know, paying the wages of the people who work in the arenas, and that's not going to last forever. And you know, we had the $2 trillion bill, but it may not be enough. We had $1 trillion in 2009. A lot of people think that wasn't anywhere near enough, and that helped the recovery. The Paul Krugmans of the world, the recovery there was way too slow. And I'm you know, I think there's potentially big shocks to the system, and we're right in the middle of it, and we'll have to figure it out. Okay, so new normals in healthcare. I'm going to start with you, Michael. We'll wrap up this whole session. It's been a lot of fun argument, which is what I wanted the whole thing to be. What's your quick sense for a new normal?
I think the new normal is going to depend on how many people die. Right now, we've had a lot of projections and all the rest. If you have a lot of people dying and a lot of people personally touched, that will change the politics, it will change the economics. And we simply don't know. I mean, all of us on this call have projected faster change in healthcare than has happened. So I'm, if the reimbursement for telemedicine follows, great. Otherwise, we go back to see your doctor, wait in the waiting room. So I think there are going to be significant changes. And the last thing I will say is that, especially this is appropriate looking at Anish in his surgical scrubs, right? Is we're talking about healthcare, but everybody in the COVID-19 is talking about medicine, right? And so if it's all about our doctors and nurses who are heroes, that's one thing. If it's about what system change we need to do to enable doctors and hospitals to do their job better, or whatever, that's something different. So I think medicine versus healthcare, how many people die, what the reimbursement and economic incentives are is going to be interesting.
There you go. Scofield gave us what the new normal will be caused by. He wouldn't tell us the new normal. But Vince, you're going to tell us the new normal.
Yeah. So my answer may surprise you. I'm not going to be a fortune teller. We don't know what that new normal is going to look like. And, the best we can do is probably begin to discuss it. It's probably going to take a few years to get us there. I think one area that I would say is I've been seeing framed incorrectly is, do we have public safety or do we have privacy of data? That's a false dichotomy. We should be thinking about a new normal that includes both of those.
Yep, right.
Brian.
Things we've already covered. I think this is going to be tremendous upheaval. I think that there's a lesson in how poorly the United States has handled this problem, that we're handling it like Italy did, not like South Korea did or Singapore. There are simple things that we could have done that we have willfully not done, and there will be certainly thousands of people who die as a result of that. And there's a reckoning, but the system is going to change in part because of all this.
Anish, your new normal.
I think I'll echo Mike's point. It's still too early to tell. It depends on what happens over the next week and 2 weeks about, if we see a catastrophe on the scale of Italy, and we see that happen in 5, 6, 7, 8 major metro areas in the U.S., then yeah, and it's going to be a huge. I think that's going to create a big push for some type of systemic change. Whether or not that's in a positive direction, I don't know. But
that'll be our next.
If we are, I'll say that if we are able to control this, if we are able to keep the lid on New York, if we are able to, in a regional manner, like Fauci and Birx have been saying, we're able to kind of lift the lid regionally with mass testing plus serologic testing, and we come out of this hit not as hard as we have, then I think I think there will be the good will be that it'll demonstrate some of what that even if we're late to the party, we were able to handle it in some manner. I think the bad parts of it will be that we'll probably go back to status quo type stuff. So I mean, I'm not holding out hope that this telemedicine parity that currently exists, which people have rushed through emergently, and people have suspended HIPAA to allow me to like FaceTime and Skype some of my patients who have trouble with whatever. I have very I'm not optimistic at all that that's going to continue. So anyways, yeah, bottom line, I think the story, the next 2 weeks will really tell the story in terms of can we contain this to New York and the surrounding areas, or is this going to spread like wildfire to multiple metros, and not just a nursing home in Chicago or someplace. Is it going to actually spread the way it's spreading in New York City? So that'll be the key.
Ian.
Well, I agree with all the points that we're not going to get to the new normal unless we get through the immediate crisis. And I think it's in the short run, stay home for those of us who are lay people, and let's do everything we can to get the resources for the front line to manage the surge. And let's not go back outside till it's safe. And I'd like to see a plan for how to establish what safe looks like. And people should be thinking about that. But in the short run, the only variable you have control over is your own behavior, it seems to me. And that is keep away from folk as much as we can and protect those caregivers.
I'm trying to get my kids away from me, but they're already breaking in. Grace.
Okay, so I think that across the board, no matter what your role is in healthcare, I think we have this reemergence of committing to do no harm and emphasis on social responsibility from each one of our standpoints. What does that look like? I think I have to say that patients and care partners, it proves, want access to technology in the appropriate disease state and settings. And we want the telemedicine and the tools and technology to help us in our care and the management of our care as potential consumers. I think we didn't discuss it here, but there's going to be a severe impact on our frontline caregivers, on their mental health. We already were operating in a burnout and moral injury state before. What are we going to deal with? How are we going to deal with this now? And then I think it also highlights, we also didn't talk about it here, but the importance of credible evidence-based medicine and science. There's a lot of quackery out there. And here now we're following the CDC, we're following the scientists, we're following medicine, we're hungry for the facts and things that are credible. So that reemergence and in a pandemic state is important because it's nothing that we've unfortunately had to ever experience. And I think the tolls of a pandemic have been lost on us, and how fortunate we are to have medicine and science.
Well, I'd like to remind you all that after the Black Death, where 1 in 3 Europeans died, came the Renaissance. So it's all so maybe we'll get there in the end. But as you all say, we want to get through a lot before that. All right. So now I'm being joined by the rest of my family in my run. It's time to. The dog didn't come in, but it's time to wrap up. It's the end of the second edition of the THCB gang. It's been a lively and fun discussion. We're all involved in the agreement that we need to get through this. I want to thank Anish Coker from Philadelphia, Brian Clever tuning in from Charleston, South Carolina. Is that right, Brian? Somewhere.
Charlotte, North Carolina. Vince Corrales from somewhere in the woodsy
Boise, Idaho.
West Boise, Idaho. Michael Millis in Chicago. Ian Morrison in the wilds of Menlo Park. Grace in New Jersey with the New Jersey hair. Thanks, Grace Cordovano. Ian Morrison down in Menlo Park. Myself in Northern California. Thank everyone for being on this, and we'll look forward to seeing you same back time, same back channel, 1 o'clock Pacific, 4 o'clock East Coast. Unless you're listening on the podcast, in which case you can have this anytime you like on Thursdays. Thanks all. See you next week.
See ya.
Thanks much.
Bye-bye.
Thanks, Matthew. Thanks all.